Evening, colleagues. All right. I think we can start.
Please go ahead. Thanks.
Yes, please. Thank you very much, Karen. Thank you. You're always helpful. Thank you. Yeah. Good evening, colleagues, everybody. Yeah, I wish to welcome you here today. My name is None Ramonati. I'm a gastroenterologist here in the University of Free State, Universitas Hospital. So I wish to welcome you on behalf of the GECO, which is hosted by the Gastro Foundation in association with the Project ECHO from the University of New Mexico. This GECO Fellows thing is run every second Monday at 6 o'clock or PM, that is 18 hours. And then at the end of this, the chat will be open for questions. So for now, I wish to welcome Dr. Innocent Francis. I tried to learn your surname, but it was quite long and difficult. But I'll do that. I'll do better next time. Don't worry, Innocent. All right. He is from University of Cape Town, Hospital Hospital. He's going to be talking to us about the Barrett's esophagus and the associated esophageal cancer. So without further ado, I'll come off and then I'll let you. So welcome, Dr. Francis.
Yeah, thanks. I'll be sharing my slides now. If you can see my slides.
I can see them this side, so I think if I can see them, everybody should be.
Francis, please put your video on as well.
We need to see you.
Sorry, my video?
Switch your video on so we can see you as well.
It's all right. Thank you, Stan.
Thank you.
All right. Thank you so much, Dr. None. Just to say that my surname is actually Francis, and my middle name is the one that is quite lengthy. Quite a number of persons have struggled with that name, so you're not alone. It is called Ekbarola Gweziba. So, yeah, it's interesting name with a meaning, means there is power in the hands of God. Yeah, that is just an interlude. So thank you once again. I'll be taking us through Barrett oesophagus and oesophageal cancer. Okay, by way of introduction, so Barrett oesophagus is a transformative process in which the metaplastic columnar epithelium replaces the endogenous stratified squamous epithelium in the lower portion of the esophagus. It is an adaptation that is as a result of gastroesophageal reflux disease, which damages the endogenous stratified squamous epithelium and over time has the potential to predispose to development of adenocarcinoma of the oesophagus. So in trying to look at Barrett's esophagus, there are key themes that are very important to take note of when it comes to the definition of Barrett's esophagus. One thing that one need to consider is that there has to be the endoscopic recognition of a salmon color mucosa into the tubular oesophagus. It should be extending at least 1 cm proximal to the gastroesophageal junction. And also it must be confirmed pathologically to contain goblet cells. And I put that as an highlight because different guidelines have some various comments regarding the presence of goblet cells as a diagnostic criteria. And on that note, I want to say there are certain controversies that do exist when it comes to defining Barrett's esophagus. In general, the consensus is that most professional guidelines, including the AGA, require the presence of intestinal metaplasia, which means the presence of goblet cells. And that is because of the increased risk of oesophageal adenocarcinoma when there is the presence of goblet cells. Although the guidelines from the British Society and the ones from the Asian Pacific region do not require this. And the American body based their evidence based on a study that was done in Northern Ireland. So it was a study that included about 8,522 patients with Barrett from the Northern Ireland Cancer Registry, where the risk of oesophageal cancer was elevated in patients with intestinal metaplasia at an index endoscopy compared with those without the goblet cells, with hazard ratio of as high as 3.54. Therefore, they consider that as being a key factor in defining Barrett esophagus. Also, in a case series of 45% with Barrett or EAC, frequent copy numbers alterations targeting cancer-associated genes were found in tissues with intestinal metaplasia, but no such changes were encountered in columnar metaplasia without goblet cells. Therefore, they affirm that you need to have that for you to define one as having Barrett. On the contrary, the single center in UK study where they have 688 patients with a median follow-up of 12 years found no difference in cancer risk for those with columnar line oesophagus or without intestinal metaplasia. In a similar manner, a multi-center UK study of 1,751 patients found a similar cancer risk in patients with and without intestinal metaplasia. Therefore, they do not seem to include this in their own definition. But a big issue remains that if you try to delete the goblet cell from the diagnosed criteria, you are going to have a large pool of patients where it will become difficult to survey this group of patients. And also there will be cost and quality of life implications as well. It may also denote that samples might possibly be erroneously collected from the proximal stomach. And that was why possibly don't have the goblet cell. So on that note, it becomes a bit tricky to remove the word goblet from the definition. In terms of the pathophysiology of Barrett esophagus, it is believed to occur as a two-stage process. And the first step, which occurs relatively quicker over a period of few years, involves a transformation of normal esophageal squamous mucosa into a simple columnar epithelium which lacks the parietal cells, and that is known as a cardiac mucosa. As a result from chronic repeated episode of refluxing gastric acid into the squamous mucosa. And this is said to be associated with increased intracellular space which allow the hydrochloric acid molecules to permeate down to the stem cells in the basal layer and stimulate afferent nerves, leading to the symptoms that we experience with the reflux, and also with the squamous cell transformation to simple columnar cells. Now, the second step, again, it took that occurred with, over a very long period of time, about 5 to 10 years. So the steps are a bit more slower in this case. And this is being influenced by genetic and environmental factors and follows two pathways. One pathway is known as the gastric differentiation, and this leads to formation of parietal cells within the gland below the columnar mucosa through the expression of the gastric genes. Now, this pathway is said to have some protective mechanism because it is not a pre-malignant condition. It is said to be a protective way against the acid that is being built up within the esophagus. So the presence of this initial transformation into a cardiac mucosa has been supported by objective markers of the reflux disease itself, including the incompetence of the lower esophageal sphincters, as well as increased acid exposure in the esophagus when you do a 24-hour pH monitoring. And also that this group of persons do have erosive esophagitis as well as hyatocyanemia. Whereas in the second category of persons, which is the group B set of persons, they have what they call the cardiac mucosa undergo expression of intestinal genes causing the formation of goblet cells within the columnar mucosa. And this is known as intestinal differentiation. These are the set of persons that do progress to the Barrett esophagus. So the presence of this intestinal transformation into a cardiac So these are the group that do predispose to the Barrett esophagus and subsequently to the adenocarcinoma. Going further in the pathophysiology, there's also the role of the gastrobiliary reflux as well has been implicated. So there is a good amount of evidence that support the role of bile components alongside with the gastric acid as being the two main factors that lead to Barrett and subsequently adenocarcinoma. And this evidence is a bit robust. It has been shown that the acid reflux results in formation of the pH gradients along the metaplastic segment that enables the optimal bile salt solubility and hence its entrance into the epithelial cells, causing activation of signaling pathways that eventually evolve into the Barrett esophagus. The bile salt also causes injury to the epithelial organelles, including the mitochondria, leading to generation of reactive oxygen species as well as oxidative stress and DNA damage. The bile salt also induces a pro-inflammatory cytokines which activate the NF-kappa B pathway. This pathway is known to prevent apoptosis and then prolong the existence of those cells. Now, the bile acid also causes other activities as well. One of them is that it tends to lead to the production of NF-kappa B activation and then that eventually leads to the activation of CDX2. The CDX2 is known to cause intestinal differentiation and development of intestinal metaplasia. Also, the NF-kappa B that is being produced with the bile acid directly activate the MUC2, which is needed for cellular reprogramming from squamous to intestinal differentiation. It is also known, the bile acid is also known to inhibit the notch signaling pathway. So once this pathway is inhibited, it leads to increased production of the HAT1 and the CDX2, which are already known to predispose to intestinal metaplasia, and therefore the formation of a Barrett esophagus. Also, the bile salts are also known to activate the H-Hock signaling pathway as well. This pathway is normally observed during embryogenesis and is absent in squamous epithelium. And the H-Hock also lead to expression of SOX9, which is normally expressed in the colon. And one that is expressed, and then goblet cells are easily formed as well. So bile salts have been known as one of the possible causes for Barrett esophagus along with the bile acid. Now, this pathway just shows how the bile reflux mediates the formation of the Barrett esophagus. So it leads to formation of the reactive oxygen species, as well as leading to production of several cytokines. And these cytokines tend to then promote more of inflammatory processes like the recycling process. And then also, it eventually leads to formation of the NF-kappa B, which eventually inhibit apoptosis. And then once you inhibit apoptosis, it then prolongs the life, and then there is also increased proliferation of the epithelial site as well. Therefore, it now increases their numbers and eventually the Barrett esophagus as well. Again, this one tends to look at the role of the interleukin 6 as well as one of the cytokines being released during this process as well. Now, the interleukin 6 tend to activate the JAK-STAT pathway, and the JAK-STAT pathway then translocate into the nucleus and then now leads to the production of the BCL-XL family. The BCL-XL family are also anti-apoptotic, and then therefore it suppresses apoptosis and then now increases also angiogenesis and multiplication of the cells as well. So these pathways whereby the bile salt act seems to significantly show that it does play a role in terms of the genesis of Barrett esophagus. Now, if you look at if you do a biopsy of the Barrett, it does show that there are many different kinds of cells that are there. So there is a lot of heterogeneity in terms of the cells, and they are also polyclonal, as well as a mosaic-like spread of the metaplastic glands. And the big question that do arise is that do all the cells originate from just one point, or could it be that there are many spots where they all contribute to the metaplastic cells? It has been proposed that it seems to have may possibly come from more than one area, and there are 6 cellular origins that have been postulated. And the biggest, what they said is that it is as a result of a transcommitment of a multipotent stem cells and progenitor cells, and these cells seems to originate from different angles. So they said the stem cells and progenitor cells of the squamous cell epithelium possibly is one of the origins. Another origin is from the gastroesophageal junction as well. Another origin that they also said is possibly from the submucosal glands and the duct. They also thought that maybe it is from the first oxygentic glands as well. And then another area is from the residual embryonic cells, and then also from possibly the bone marrow-derived multipotent stem cells. They felt that possibly all these areas will have played a role, and that is why you have the polyclonal and then also the heterogeneity when you do a biopsy of the area as well. Now, this pathway just shows various contributions. So this is from the squamous epithelium. This is from the submucosal area. And this is from the first oxyntic. This is the bone marrow. Now, eventually, all of them lead to the formation of the cardiac metaplasia via the role of various mediators like the H4 pathway and then the notch-based suppressor and the CDX. And then eventually, it now leads to formation of the intestinal metaplasia. And then eventually it now goes to form the adenocarcinoma. There is also the role of genetic event as well that seems to play a role in Barrett esophagus as well. So the neoplastic progression in Barrett oesophageal adenocarcinoma can be explained by several important molecular and genetic events. And one of them that has been widely discussed is the issue of the loss of heterozygosity, which means that maybe you lost one of the genes from the mother side or from the father side, depends on the one that you lost. And what has been implicated is mostly with respect to the locus 9, so chromosome 9 band 21, and that of 17 and 13. And this leads to the genes, or these chromosomes are responsible for the CDKN2A gene and the P53 gene. It has been shown that if you inactivate the CDKN2A, that this is commonly seen, this commonly leads to dysplasia, and it is seen as part of the pathogenesis in Barrett esophagus. And then also that P53 is responsible for the progression and accumulation of mutations in about 72 to 82% of mutations that are identified in esophageal adenocarcinoma. So it is also noted that with P53 genes abnormality that you can see them when they have dysplasia, they can be detected quite early as well. So they seems to play a role in the etiopathogenesis of the Barrett and adenocarcinoma as well. And there are risk factors that are associated with the Barrett. Now, in the United States, it has been shown that though the white individuals who are over 50 years of age were prone to Barrett as compared to the Hispanic and the Asian population, and it was lowest among the Black group. And there are several other factors that seem to predispose to the development of Barrett esophagus, and these include those who have the reflux disease, peptic strictures, as well as erosive esophagitis. This seems to confer about a 5-fold increase in the risk of Barrett esophagus over a 5-year follow-up, with a risk of about 5.2. It is also said that those who have a high body mass index seems to have a higher risk as compared to those who have a lower body mass index. And similar studies have also shown that if you have a high waist to hip ratio, that your risk of having a Barrett is also higher as compared to those who have a lower or normal one as well. Now, once you have Barrett, because we suspect that people can have Barrett, one of the big issues is that are you going to screen everybody that you think, everybody who's above 50, or whom are you going to screen? So that becomes a big dilemma. Now, in terms of screening, there are things you have to consider. So since you can't screen everybody, there are those that you consider as having risk factors that you will likely want to be screening for Barrett esophagus. So therefore, it is said that you can screen those persons who are those who are having chronic reflux disease with multiple risk factors of at least 3 of the following, that this group can be selected and then screened as against going for the population screening for Barrett esophagus. So if you have 3 of these ones, those who are 50 years and older, the white race and male sex, and then obesity. But obviously, if there is a family history of Barrett esophagus or esophageal cancer, then you don't have to consider more. That is, if a first-degree relative is having any of these, then you don't have to have these 3 factors. You may have to then tailor down the factors, can be 1 or 2 factors, and then you can screen this group of persons for Barrett as well. Now, in making a diagnosis for Barrett, you have to combine more than one factor. So, and one of the key things that you have to consider is to recognize the columnar epithelium that is more than 1 cm proximal to the gastric fold based on the universally accepted Prague criteria. And then you have to do a targeted biopsies, and then with the histological confirmation of the columnar metaplastic changes. With those ones, then you can make a diagnosis. I will say a bit more when it comes to how to biopsy them in order. But then, in terms of histological confirmation, one of the things that one has to consider is that sometimes you can accidentally biopsy the cardiac side, the gastric side. So one has to be very, very careful where you obtain your biopsies as well too. At least 8 biopsies are obtained, and also the greater the length of the columnar line epithelium, then the higher the likelihood of going to have a positive biopsies, as against if you have a very short segment of your Barrett. Apart from the biopsies, there are also some non-endoscopic technologies that can be employed as well. And I think the ASGE recommended one of them. So that is soluble non-endoscopic cell collection device, such as the cytosponge, combined with the cytopathological assessments and a biomarker of the TFF tray, that is the trefoil factor tray, can be used as an alternative to endoscopy for case finding. But I know we don't have this. I'm not sure whether we have that in our own society. But there are also other technologies as well that are also coming up on board, the oesophageal cap or an inflatable silicone balloon, such as the ESOCheck. But these have not been recommended by the ESGE guideline. They said that there is still need to do a more robust study in most of these other ones. But what has been recommended is the cytosponge that can be used as an adjunct or as a non-endoscopic method for it. There is also the issue of adjunctive markers of dysplasia that can also be employed as well. And some of the markers that have been implicated are things like the proliferative cell nuclear antigen and Ki67, and then a cyclin D and also P53. It has been shown that the distribution of Ki67 staining correlates reasonably well with the degree of dysplasia. The only drawback is that for even the regenerating epithelium, that can also show the Ki67. So that seems to be like a drawback as well too. Also, P53 staining had been shown to be proportional to the grade of dysplasia and may have a predictive value in assessing the risk of malignancy. And this was shown by a study done by Castellin. And in that study, they showed that P53 staining was seen in 11% of those without dysplasia, but those who have low-grade dysplasia, they had about 8% of the staining. And if you have high grade, about 83% of the staining was present. And for those who had 83 in high grade, and if you have the adenocarcinoma, about 100% of the P53 mutations we are seeing. So that can be an adjunct as well. There are also other markers as well that are also coming on board, and one of them is the methyl acyl-CoA and the loss of membrane grain as well. It has been shown that in adenocarcinoma and in a dysplasia, you can have as high as 82% specificity and about 96% being sensitive. So it is a marker that is coming on board that I think needs further evaluation and possibly be used as an adjunct when it comes to making diagnosis of dysplasia and adenocarcinoma in Barrett. So in terms of surveillance, it is said that the technique should utilize high-resolution white light endoscopy for us to properly evaluate the mucosa in a thorough manner, including insufflation of the lumen and to do a retroflexion and inspection of the gastroesophageal junction. And the gold standard for this sampling of Barrett esophagus is based on the Seattle protocol, which was first described in 1993, about 30 years ago, which consists of 4-quadrant biopsies at intervals of every 1 to 2 cm. So if you have an area that was possibly had a dysplasia before, then you need to go 1 cm for every biopsy, 4-quadrant wise. And that's separate. If you have any area of abnormality or irregularity, then you need to biopsy that area and then put separately in a different container. So this one just shows the length of it at every 1 cm, every 2 cm. You go the 4-quadrant, go the north, south, east, and west pole, and you do that as well. And if you have a tongue of Barrett, then you also biopsy in that tongue of Barrett as well. To every cm, you biopsy that area as well. And they said, ideally, this is not very realistic, but this is what they recommend. And ideally, you need a minimum of 1 minute inspection per time per cm of Barrett length. And that's going to take a very long time if you have a long Barrett length to do that. And then you also need a photo documentation of the landmarks, the Barrett segment, including 1 picture per cm of Barrett's oesophagus length, and the esophagogastric junction into reflection as well need to be pictured as well. And if you see any visible lesion, you also photograph that area as well. And you also need to use the Pratt classification when you want to grade, when you want to measure your Barrett. And then if you see any lesion, use the Paris classification to now grade your lesion. Again, collection of biopsies from all visible abnormalities need to be done as well, so that those ones should be kept in a separate pot. In patients with Barrett undergoing surveillance, we recommend the use of chromoendoscopy, including the virtual chromoendoscopy, as well as the settle protocol biopsies method, and that you also, and you have to biopsy accordingly, just as I discussed earlier on before. Now, for Barrett with a maximum length, extent of more than 1 cm, but less than 3 cm, you should survey them every 5 years daily, provided there is no dysplasia seen. But if you have a Barrett that is between 3 cm and less than 10 centimeter, then you should survey every 3 years. And if you have a Barrett that is, for which the length is more than 10 cm, they said ideally you should refer to a Barrett expert center for surveillance endoscopy. Just to know that for patients with irregular Z line and that are less than 1 cm, you should not routinely biopsy these specimens, and there should be no need for surveillance as well. And also, biopsy should not be obtained in mucosal areas with endoscopic evidence of esophagitis, if you have erosive esophagitis, until after you've intensified treatment and the area is well healed, because it can give you a false result as well, and you can actually miss lesions. Sorry. Sorry, I was getting frozen, sorry. This one just shows a table that looks at the fact that there are many guidelines from various bodies. So they have some slight variations. I don't intend to go into details for this, but then if you look at the AGA guideline, the AIGA guideline, and the BIG guideline, they have some slight variations in terms of your screening method for them. Just to zoom and show us that if you look at the ESG guideline for 2017, they said if you have negative for dysplasia and a Barrett is less than 1 cm, it said no surveillance. If it is between 1 to 3 centimeter, then every 5 years. If it is between 3 to 10 centimeter, is every 3 years. If it is more than 10 centimeter, you refer to a Barrett expert center. And then consider discharge for patients with limited life expectancy and for those who are advanced. And they were talking about those who are more than 75 years of age, that you don't really need to follow them up again. Or if you have a life expectancy is less than 5 years, you don't need to follow them up again. Now, if you do your biopsy and you have the indefinite for dysplasia, what do you do next? So if the initial biopsy revealed indefinite for dysplasia, then anti-reflux therapy is optimized, often with a PPI, a BD dosing, and if the patient have not already been on the high dose before, and then you repeat your scope within 6 months to see. Now, if you repeat your scope and the results are still indefinite for dysplasia, then it is advised the patient to have a surveillance 12 months after then. Again, if you biopsy and then you now have a low-grade dysplasia or high-grade, then you follow the protocol depending on what you find on your endoscopy and your histology. And if it is a low-grade dysplasia that you see on the histology, it is recommended that this is confirmed by a second pathologist to ensure that the low-grade dysplasia is correct and to be certain that there is no high-grade dysplasia or no cancer. That is always heterogeneity in reading the histology, so that's why we need more than one pathologist. And preferably, a GI pathologist should be the one that should be used for us to get the maximum yield in terms of the histological report. And if we have a low-grade dysplasia, endoscopy therapy is also suggested to reduce the risk of progression to high-grade or to cancer. But they also said that endoscopic surveillance is also an acceptable option if you deem fit to do so. And it's recommended that you do it at 6 months later than 12 months and then annually. This one just shows what one sees in a low-grade dysplasia. And if you look at what you see is the prominence of the nuclei that if you look at how in the stratified area, they are very, very prominent. And then the pencil-like cells of the nuclei as well, too, that is also shown in this one. But one thing is that if you look at the stroma appear to be within normal limits. So that is commonly seen in those who are having the low-grade dysplasia. And the architecture of the epithelium is not really dysplastic in these categories of person. But if we have high-grade dysplasia for anyone with Barrett oesophagus, you don't really need to do a surveillance in this group, but these people need to be treated, and your choice of treatment depends on the expertise of the person as well. So you can either go for endoscopic or you can go for a surgical approach in these categories of person. And this one just shows the histology of a high grade. If you compare this to the other one, and what you see is that you see the polymorphism of the cells, that the sizes vary. Some are small, some are big, and that is commonly seen in those with high grade dysplasia. And then you also see the goblet cells as well in this category. Again, you also see the fact that there is this crowded architecture that's also seen if you look how crowded they are as well. And this is commonly what they see in the high-grade dysplasia. But then why confirm with the diagnosis with a second pathologist? So several studies have shown that there is a significant intra-observer variability in the diagnosis of Barrett oesophagus, particularly with indeterminate for dysplasia and low-grade dysplasia. So there have also been studies demonstrating the case of low-grade dysplasia being mistaken for non-dysplastic lesions in Barrett. So therefore, there is a need for a confirmation with a second pathologist. And now to enhance the diagnosis of Barrett, there is also the role of advanced imaging as well. And this is because of the fact that it is easier to miss lesions as well, and therefore they recommended a high-quality endoscopic examination with careful inspection of the Barrett segment and adherence to the protocol as already discussed earlier. Now, apart from looking at these ones that we mentioned, you need to also look in an in-depth visualization of the abnormalities. So majority of adenocarcinoma found in Barrett are flat and non-polypoid and can easily be missed as well. And sometimes if you take random biopsy, you are prone to missing points where there are lesions as well, with error sampling as well. Therefore, this advanced imaging is meant to mitigate for these errors that could happen. It seems to enhance the assessment and hence not to miss much of the lesions. And some of these advanced imaging include the virtual chromoendoscopy, and we know about the NBR, know about the eye scan that is being used. There is also the volumetric laser chromoendoscopy as well. And there are also other modalities like the wide area transepithelial sampling, which is a two-dimensional computer-assisted technique that has been used as an adjunct to traditional forceps biopsy as well. And it seems to also enhance when used alongside with the normal biopsies. Other advanced imaging that are also important is the use of the EUS. Now, EUS has many roles, even in terms of trying to determine the the degree, the depth of invasion, if there is concern for cancer, the US has a role to play in that area as well. And also in early staging of, in the early stage of neoplasia, US is also able to assess for lymph node involvement. And there is also the role of AI that's also coming up on board. And over the last 20 years, it has been coming up and becoming more and more prominent. Mostly it is used in many of the upper endoscopes. And I think over time, it is going to become very, very critical in our procedures, in scoping procedures as well. So when do we stop surveillance? So if a patient attains the age of 75 years of age at the time of the last surveillance endoscopy, or if the life expectancy is less than 5 years, they do recommend that we can stop surveillance in this group of persons. In terms of the management, so non-dysplastic Barrett can progress to dysplasia and subsequently to oesophageal adenocarcinoma. And the risk factors for progression include the length of the Barrett, those who have heterocyania, and those who have the P53 loss of heterogeneity, and then aneuploidy. And just to mention that the management often depends on the grade of the Barrett oesophagus as well. And the treatment modalities include both endoscopic eradication, surgical management, and also the adjunct medical management as well. So what if we see a non-dysplastic Barrett? One thing about them is that they have a lower progression to advanced disease. And they said that they can develop low-grade dysplasia in an incidence of 4.3% per year. It was also noted that in 1 in 50% with non-dysplastic Barrett, if you do multiple biopsies, that they ended up progressing to high-grade dysplasia at an interval of about 6 years old. So it's very important in their surveillance as well. And the incidence of high-grade dysplasia and EAC from non-dysplastic Barrett was found to be 11.2%. So Barrett in this category does not require eradication therapy, but what they need is regular surveillance in about every 3 to 5 years. What if it is a low-grade dysplasia? One thing about low-grade is that they can either be mistaken for non-dysplastic lesions or indefinite for dysplasia with esophagitis. And there is a high variability of low-grade dysplasia diagnosis among the pathologists, and therefore you need a second pathologist for you to really verify and therefore decide what treatment to give. And patients with low grade should be treated with a high dose of PPI. If repeated endoscopy demonstrates mucosal abnormalities or confirmed low grade by histology, then they need eradication therapy. That is in terms of using endoscopy to eradicate them, given that they have a moderate risk for progression to a more severe phenotype. And eradication of low-grade dysplasia should have surveillance endoscopy 6 months later after you've done eradication, and then do annually. What if it's high grade? This group of category of persons, they have a higher risk of progression to adenocarcinoma with a weighted incidence of 6.58 per 100 patient years in patients undergoing regular follow-up. Mostly if you have a longer segment, the risk becomes even higher. Initial grade of dysplasia are the strongest prognostic factor in the development of adenocarcinoma. So these persons do need eradication, but they don't really need a surveillance. That is saying no treatment, but just surveillance. So what they need is eradication in these categories of persons. The recurrency rate, however, is found to be about 13.5% after treatment. And after treatment, you need to have a follow-up scope about 3 to 6 months in the first few years following therapy, and then annually after that. Then the next thing I wanted to look at is oesophageal cancer. So oesophageal cancer is one of the, so a Barrett is a precursor or is a pre-malignant condition for oesophageal adenocarcinoma. And in terms of the staging, it is based on the TNM staging. So early stage cancer is divided by depth of invasion into T1A and then T1B. So T1A are those that occur within the mucosa alone, and then T1B is the submucosal type. Again, because the cancer has a poor prognosis, treatment is indicated even if we have the early type of cancer. And you also see that the T1A have a very low risk for lymph node metastasis, very, very low, as low as 0 to 1.8%. Again, T1A is subdivided into whether it's a moderately differentiated or polydifferentiated type. And this, the one that has a poor prognostic one is a polydifferentiated type because of risk of lymphovascular invasion as compared to the one that is moderately differentiated. And this one just shows what the T1A and then the T1B means, and then the and then the T2, T3, and then the T4. So if we have it within the mucosa alone, so this is the T1A. It is not going beyond the submucosa. And then if we have it going beyond the submucosa, it is now the T1B. But the T1B does not extend into the muscularis mucosa. And then the T2 and then the T3 accordingly. And the T4 is the one that goes and extends into the adjacent structure by the aorta as well. The T1A and the T1B are further divided into both M2, M3, and then the SM1, SM2, and SM4. I don't want to go into details on that aspect. As you say that the submucosal type 1B cancer has been associated with a high rate of lymph node metastasis as compared to the T1A that has a less lymph node metastasis. They are further classified into SM1 to 3, with SM3 having the most depth with poorer prognosis. SM1 and lesions less than 2 cm have better prognosis compared to the other subcategories. And endoscopy treatment success rate for SM1 lesions is up to about 97%, and that has been reported in some studies. Given a confounding result, careful assessment of submucosal invasion assessment is very, very important. So you need a PET scan with CT and EUS for you to be able to decide the depth of involvement, for you to rate them and then treat accordingly. And then the T2 type, these are the locally advanced oesophageal cancer which invade the muscularis propria. It is aggressive, characterized by poor 5-year survival, ranging from about 17 to 23%, even in patients who receive treatment. So that's a very poor prognosis in this category, and that is why the screening is very, very important for us to avoid the development of this cancer. So treatment involved the neoadjuvant chemotherapy with a radiation plus surgical resection, which shows the survival benefit over treatment by surgery alone. And even at that, it is about 47 versus 33% respectively over a 5-year period. So it has a very poor prognosis. Now, in terms of the treatment modalities for these conditions, we said that EMR is a good option. So it's widely used technique for diagnosing and eradicating Barrett oesophagus, mostly if you have the superficial ones with dysplasia and then neoplasia. You can use EMR. This technique involves endoscopic evaluation of mucosal tissues followed by targeted resection of the visible mucosal abnormalities suggestive of dysplasia. And the pool eradication for this about 79.6% for it to have for complete eradication. And it can be up to as 94.9% as well for those who have been neoplasia, because they are seeing a visible lesion, so you can easily eradicate that. But then those studies show a high heterogeneity of about more than 25%. The risk of recurrency is still also there as well. The poor recurrency rate for if you do AMR is about 0.7% for adenocarcinoma, and for dysplasia is about 12.1% if you have intestinal metaplasia. Then also ESD is another method that can also be used as well. This modality aims to remove the entire lesion, accommodating for varying depth and then and width. And the pool data demonstrate that ESD cure is up to 92.3% compared to EMR of 52.7%. It is said to have significant cure rate compared to the one of the EMR. And it is very important. It said it is very good when you are dealing with T1B SM1 lesions. Then you can also use the RFA as well. You can use RFA to eradicate circumferential lesions when they are having a dysplastic Barrett. It is often used in conjunction with the EMR for complete diagnosis and for treatment. And also, if you have nodular Barrett requiring EMR, for appropriate resection and non-nodular Barrett benefiting from targeted area as well. So once you have eradicated, once you remove the nodular lesion, then you can use RFA to now burn off the other surrounding area. So it is commonly the first line therapy given the efficacy and the safety that is involved in RFA with less side effect compared to other ones, although you can still have bleeding with strictures as well, because we are now going around the circumference of the esophagus. Other things, again, that can be employed is cryotherapy. I think the benefit of cryotherapy compared to RFA is that you have less tissue damage in them. Therefore, pain is less compared to RFA, and it can be performed every 3 months as well. So it has some good benefit, although there is no head-to-head trial compared to RFA, but it is said to have less pain and because of less tissue destruction, and it has a good outcome as well. Then there is also the issue of the hybrid agon coagulation as well that can also be used. But this one, you combine this with a submucosal injection of a saline before doing your APC in this category. From their findings, they said that it also has a good outcome as well, up to as high as 8.4% in the eradication as well. So seems to be a very good option to also employ. And then management post-endoscopic eradication of Barrett is also another thing again we need to consider. The reason is because the acid reflux is a driving force in initial development of Barrett esophagus. Therefore, we need to see that the people are well suppressed in terms of the acid built up. So adequate suppression is very, very important. And it is advised that we use double dose PPI in these categories of persons. These are just diagram that give a summary of most of the treatment options. So if you have Barrett with dysplasia and or with adenocarcinoma, if you one thing that if you have a flat dysplastic Barrett esophagus, then if you confirm dysplasia with a second pathologist that is dysplasia, then you can do your endoscopic ablation in these categories of person. But then if you have a tumor that is invading, then you have to also do your other imaging as well to also see what the depth of it and the extent of involvement. If you have a low grade or high grade or low risk T1A, and it is not a poor tumor type and no lymphovascular invasion, you can also use endoscopic management as well as ablation for treatment in this category of persons. If you have high risk T1A with a poor tumor differentiation, with the risk of lymphovascular invasion, then you need to consider oncological staging. But if no meds, then consider individual treatment on one-on-one basis in this category. You can use both your chemo and then your radiation in these categories of person. And don't forget the role of AUS as well in trying to assess the depth of it and the level of involvement. If you have a low-risk T1B, which is submucosal invasion, and there is no poor tumor differentiation and no lymphovascular invasion, again, do oncological staging. And if no meds, then you can do also endoscopic, you can do endoscopic treatment of the follow-up, including upper endoscopy and EUS. And then if you do EUS and there is no depth and there is no invasion beyond the mucosal layer, then you can also do your beyond the submucosal layer, then you can do your ablation in this category of persons as well. Then if there is high grade type T1B involving the submucosal invasion, and there is if it is more than 500 micrometer and or poor tumor differentiation with or without lymphovascular invasion, again you do oncological staging and then you manage them based on the staging of the lesion that you've seen as well. And then they said, again, if you have Barrett with dysplasia, and if you are able to successfully eradicate this category of person endoscopically, there is no visible lesion again, and nothing more, what do you do next? So if you have your baseline diagnosis of low grade, then you follow up endoscopy after 1, 3, and then 5 years after your last treatment. But if you have a high grade, then you have a more frequent follow-up of 1, 2, 3, 4, 5, 7, and up to 10 years as well after your last treatment. I think that would be my last slide. Thank you.
Thank you very much. Thank you very much, Dr. Innocent. This is great. I hope I think I'm back. Yeah, this has been a very wonderful information, detailed overview of this Barrett's esophagus, esophagitis. We usually talk about this almost every year. And yeah, I think I will give it to you that I think you covered the signal pathways, which I think are important for a physician, maybe just to appreciate the difficulty in terms of the pathogenesis. I think you did touch on those, the different types of signaling pathways, maybe the hedgehog and the CDX, that's for the inflammation, and the JAK-STAT, you touched on that. And the genetic things whereby you probably lose there's transformation and loss of the tumor suppressor gene activities, then they become defective. I think you're talking about the T53 as an example, P53, sorry. Yeah, I think the pathogenesis for us is quite important so that we understand what's going on. I came somewhere like in embryology. It's like in the early phase, the esophagus, the entire esophagus is covered by the columnar epithelium very early. And then later, that's when the squamous epithelium, non-stratified, comes in. And it looks like it starts from the mid-esophagus and then spreads laterally to the proximal part and the distal part. The reason why I'm saying this is because I saw one gentleman, 72-year-old man, who came with dysphagia, and then we confirmed Barrett's esophagitis at 25 centimeters. He only had two, it was like kissing lesions. I don't know what was happening there, which appeared pink, and they had lost the squamous epithelium. Actually, I thought it's cancer, although it would be unlikely because it was two lesions which are opposed to each other, which means there must be something inflammatory which was going there. I'm not sure it was pill or maybe what he drinks based on the, I don't know, but yeah, it was in the 25 centimeters from the mouthpiece. So I saw that it was just localized. So it was interesting for me. And also it was a black man, so at 72, but it was benign. Yeah, and then, yeah, it looks like as to what to do once we have committed, this is low grade, high grade, the guidelines are clear, in terms of what we should do. But I think the homework is still between the endoscopist and the pathologists. In terms of the endoscopist, has to make sure that he biopsies the right areas so that the yield gets more. So I think for endoscopist, obviously can identify the area, but I think we have to improve on the tools that we acquire. We should have a way of maybe acquiring magnifying instruments. I'm not sure if they become cheap, but we have access to chroma endoscopy. And most equipment now, I think, that we have got access to narrowband imaging where they utilize certain wavelengths whereby there will be different in color that you can decide where exactly you think you want to do the biopsies to increase the yield in terms of what's the pathology. When I'm saying narrowband imaging, some companies use the word FICE. I think it's flexible spectrum imaging color endoscopy, but I think the mechanical size is the same behind that, but we need to, that's for the endoscopy, just make sure that we yield these things. As far as the pathologists are concerned, I think also it means next time we need to find out from them what is it that they're employing so that if there are any forms of staining or what they use just to make sure that they increase the yield. Because I'm worried that we might not be able to afford a second pathologist. So the only one that we have for the first time should really make it, yeah, get closer to whether is it high grade or low grade or we do nothing about it. Then there can be, when you're seeing a patient for the first time and then you're being told about this Barrett's, yeah, there's something called reactive atypia or regenerative or reactive atypia. The only difference between that and dysplasia is just in terms of the nuclear cytoplasmic ratio. The rest of the features, inflammatory features I'm talking about, are the same. So that's why we usually recommend just give patient PPI first and then let them come back maybe after 4 weeks or 6 weeks so that you eliminate these things of atypia so that you can maybe, yeah, if it's Barrett, then it's Barrett without any inflammatory processes. I am aware of some few reports whereby if a patient has some form of dysplasia and then which was missed, and then they're on PPI, they can have normal mucosa overlying that precancerous, even cancerous area. So I think these radio frequency ablations and all those modalities which I've mentioned should be considered early before you start playing around with PPS. Is anecdotal, so I think it can be debated. As far as cancer is concerned, we don't deal with that. I don't have experience at all. And then I'm not sure if in this audience, if Dr. Siabi is around, because she always comes out knowledgeable about all these treatment modalities so as to what should happen. Otherwise, we leave it to the surgeons in our side. So what I'm trying to declare is that I have no experience at all with dealing with the actual treatment for the dysplastic lesions. I don't have any experience, so I'll leave that to those guys who have something to say about it. So with that, I'll open the floor invite those guys who deal with these things in terms of intervention, or otherwise then will be a general discussion. And having said that, before I close, is that it's a general thing that with us, most of the patients that we see have got squamous cell carcinoma of the esophagus, but it's not about that. We have to focus on this Barrett's and adenocarcinoma and give it fair treatment as well. So thank you very much.
Annie, there's a question in the chat.
Try to look at this. Chat is here. This is the only question. What are the factors that govern the use of EMR or endoscopic ablation in a patient with low grade? Yes, that's why I said this one I'll have to refer to big guys who deal with these things. I have no clue at all in terms of these modalities which are employed. Is Dr. Siavi here or not? Or anybody?
I'm having a look quickly.
Hi, Nane and
Yes,
Giancarlo.
please. Yes.
I think that was a fairly comprehensive overview. I just want to add I think for the people that, well, all of us actually that do routine aposcopes, and the first point is to be aware of it, to you recognize it, and then to just be familiar with at least one of the guidelines in terms of how these things should be surveyed and biopsied and all of uh, those things. Now, with regard to when should you use an EMR, I think here's where a very careful endoscopic evaluation of the segment is required. Of course, you can add in your NBI and you can use iodine and all of that there that can help enhance your imaging. But the first point of call is to use a high magnification, high resolution scope. So you really want to use the scope in your unit that's really like good, and hopefully they all are high magnification. And if you see a area that looks slightly raised, has got any evidence of neovascularization during this careful inspection of that segment, then you sort of zoom in on it, demarcate it, and that should be the area that you focus your EMR on. So it could just be a very small area with a cap, and it's usually fairly simple if it's small and superficial. These aren't the kind of lesions you need to do a ESD or anything on. So you can just check under it, place a snare around it, and remove it. And the crucial thing there is to try and retrieve that sample for histology. because obviously it can show you how far it is and whether it's just a tumor in situ, to use the old terminology, or is it a something that has gone beyond the first epithelial like layer, or if there's concerns. Now, it'll be very unusual to see that sort of lesion in somebody who just has a C of low grade dysplasia, unless you haven't adequately sampled the segment. In other words, there were high grade areas that just by sampling error were not sampled. Usually you would see a area that requires EMR, a focus that requires EMR in the setting of high grade dysplasia. But having said that, look, if you have to do an EMR on a raised lesion or an abnormal area in a sea of Barrett's esophagus, invariably you're going to have to return afterwards, ensure that that area is now healed up and cleared. And then you're more or less obliged to go ahead and perform some form of endoscopic ablation, provided that that is still a very early, that the lesion that you resected was a T01 A lesion. And if it's anything higher with high risk features, especially from your histo, then you might have to at least consider the option of a surgical resection or offer it to the patient if they are otherwise fit and healthy. So yeah, I'm not quite sure if that answers the question. Who actually asked it?
Badruddin?
As I told you, it'll be really unusual to find a lesion that requires EMR, because if there's a raised irregular lesion in a sea of Barrett's, that usually occurs in the setting of a high-grade dysplasia. So yes, you'll still have to do the EMR of the lesion of concern that's irregular, raised, or has any evidence of neovascularization, and then you'll have to return to do a formal ablation. Ideally, if you have RFA, that's absolutely great, but I don't think too many of us have easy access to an RFA, because, we rarely see high-grade dysplasia in the state sector. I mean, in a year, we'll see a few. And now you have to spend so much on this RFA equipment just to use it and now and again. Ideally, you should have a single institute in your area, in your region. Sometimes, unfortunately, it may not be in the state sector. It may just be in private. And then you might have to make some kind of arrangement for the patient to go for RFA. But I think a fair number of us may have access to APC. Now, APC can also be used. It isn't as swift or as using RFA, but there certainly are studies that have shown that given some submucosal lift and proceeding with RFA is equally as yes, it may take you a bit longer and you may need a few more sessions, but if it's all you have, sometimes it's all you have. But for me, the key is to carefully inspect, because it's those small lesions that require EMR that can sometimes be easily overlooked. So clean the mucosa, use some N-acetyl cysteine in the saline, and really get that mucosa over the Barrett segment as clean as you can, and then use your high magnification scope to carefully look. Once you've completed the EMR of the abnormal section and you're happy there isn't anything else, then you can by all means go ahead and do your endoscopic ablation with whichever modality you have available at your institute or in your area.
Right. Thank you very much, PG. Just hope it gets clearer. So, like I said,
does it answer the question from the whoever asked it? I'm not sure who asked it.
no, it's
I don't know if
It was
Innocent
asked by
wants to
Yusuf.
add.
Yeah, from Badruddin.
Innocent, do you also want to like add anything?
I think what you've said everything. I think what they emphasize is that you can use the AMR if you have a T1A lesion, just superficial lesions. That is why you employ AMR. It is not using ones with greater depth or higher depth like T1B and beyond. So mostly T1A lesions are the ones you use AMR. Yeah.
Okay.
Right. Thank you very much. Like I said, I declared from the start that the theory part, I think I'm comfortable, but the practical next. So, but thank you, Viji. We have stages coming next month, so these things might be answered there. Most of them maybe don't. But Badruddin is happy now. It's fine. All right. With that, I wish to thank everybody now. Let me see. I have to open up this so that I can see me. Thank you very much, everybody who participated here. And Innocent, thank you very much. This is an important subject which I think was well presented, and it will be available, I think, on our website so that we can revise. I think it was wonderful. And again, Karen, thank you very much. And then, yeah, and thanks to the ECO team and the ECO India team for the support. This recording will be available on the Gusto Foundation website, like I've already indicated. Again, we wish to thank you very much again. Now, this is very important. In 2 weeks' time, I think that will be between the 2nd of April, 6 o'clock, obviously, there will be a topic which is extremely important for the guys who are going for the exams all the time. Eosinophilic esophagitis, including other causes of esophagitis. That will be chaired by Professor Mpochomo, and Dr. Hassan Ismail will be presenting. So with that, I wish to thank you all and have a great evening.
Thanks so much.
Thanks.